so let's go to the last question. How the protocol biopsy in transplant kidney improve the outcome? Mia, do you want to spend some words?
Yes, may I share the screen because I prepare one slide to answer this question.
That is good. Of course,
please.
Okay.
You should be able to share your screen.
Okay. Do you see it?
Yes, we do.
Yes, we do.
So I would like to share these slides and perhaps I can answer this question for you. So this is the lifespan of the transplanted kidney. And here is the kidney graft function over time. And you can see that if you use only classical surveillance options like serum creatinine and GFR and proteinuria, of course, we can only catch clinical events such as clinical acute rejection. And of course, if we went long enough for a permanent graft dysfunction, you can see that the chronic injury becomes at some point in time irreversible. And we know from our experience and from the literature that we want to catch these subclinical inflammatory events, specifically subclinical acute rejection. And it has been shown now in many literature that the treatment of subclinical rejection is as important as the treatment of clinical rejection. And also if you treat the so-called inflammation in chronic areas, it may also improve the outcomes because all these inflammatory lesions can be quite important. But unfortunately, these subclinical inflammatory events, you cannot catch them only with the indication biopsies. So in case of no graft dysfunction, you can catch these subclinical events only by doing protocol or surveillance biopsies, as we usually like to call them. Of course, on the other hand, the outcome of these biopsies is not very high because we know that we get useful information only about 1/4 to 1/3 of biopsies. So we now try to complement this information by doing other complementary tests like molecular tests such as donor-derived cell-free DNA, and then we try to pick the patients who would probably get some information also from the surveillance or protocol biopsies. So maybe I answer this question. So we do the protocol or surveillance biopsies to detect this subclinical rejection and subclinical inflammatory events. And even we try to adjust the immunosuppression, even if the biopsy is clean and the patient is on the full, let's say 3-course immunosuppression, we then, if the biopsy is clean, try to avoid or get rid of the steroids. If the biopsy is clean and there is no de novo donor-specific antibodies, then we have the, let's say, safe information that maybe we can proceed with late steroid withdrawal. So this would be my question. Of course, there is no head-to-head or randomized studies. Unfortunately, I think there will not be studies to compare centers which do perform protocol or do not perform the protocol biopsies. But we know that we can change the direction of this course if we treat these subclinical inflammatory events.
Perfect, Mia. That was a really very good question. And the picture, the figure was perfect.